We're good to go then?
You are good to go.
All right. Well, welcome everyone and good afternoon. My name is Ken Milne. I grew up on a farm and I've been practicing rural medicine for the entirety of my career, which is 24 years. I'm actually currently in Goddard right now, and I don't know if you can hear the bells, but it chimes on the hour on our court building downtown. So just hearing the chimes of the bell, so it must be 1 o'clock. It's time to get started. My talk is titled Urbansplaining. And if you'd like to follow me on Twitter, my Twitter handle is down there on the bottom right corner. So for my disclosure slides, I'm a nerd. And if you went to my earlier talk today, you know I'm a nerd. My comfort zone, my wheelhouse is doing structured critical appraisals of the recent publications. And I don't get any money from pharma or the medical industry. I do participate in a couple of faculties that are involved in teaching. I do offer my services to places like CMPA for medical malpractice cases as an expert, and I do hold a resuscitation pediatric device patent, which will not be discussed in this talk. So, to start with, nobody disagrees usually with me that there is a difference between rural and urban practice, but it's not a clear, demarked line. People have been arguing for decades about what is the definition of rural. And they've used various things like how far you are from a tertiary care center, population, available resources, things like that. There was even something called the Rio score, the Rurality Index Ontario, that we used in Ontario to decide just how rural are you. I've worked at hospitals that consider themselves rural, but they're only 20 minutes from a city. They have a CT scanner, a small ICU, they have ORs, surgeons, internal medicine, pediatrics, ENT, plastics, ortho, and the ER shifts are 8 hours in length. Some people may not consider that rural, but they do. And this compares to other hospitals who are hours from a city, have a 2-bed emerge, 2 inpatient beds, point of care lab. The only CT scan they can get has 4 legs. It's run by GPs, and the ER shifts, they don't measure ER shifts in hours. They measure ER shifts in days. So, rural, the definition is what you think it is. It's sort of like art. You know it when you see it, but rural versus urban is sort of a false dichotomy. It's on a spectrum and the lines are very blurry. Regardless of the differences that we have between urban practice and rural practice, I think we have more in common than we have apart. And the number one thing is that we all want our patients to get the best care possible. We just may have different definitions on what the best care is and how to deliver that care. But I think we both, rural and urban clinicians, have that common ground that we want the best care possible for the patients that we're caring for. Now, this talk, it's not meant to divide us. I know I'm preaching to the choir probably, and I do not want this to sort of put us in separate camps. I would rather have this unite us. My tongue will be often firmly placed in my cheek, and it reminds me of this Marshall McLuhan who famously says, anyone who tries to make a distinction between education and entertainment doesn't know the first thing about either. So I hope that this is both informative but entertaining to get an important message across. So it's about time that I define the term urbansplaining. This is a term I came up with a few years ago, and it was inspired by the term mansplaining. Now, mansplaining, if there are women listening, they're quite familiar with mansplaining. Usually, the explanation or the definition is mansplaining is the explanation of something by a man, typically to a woman, and usually in a very condescending or patronizing way. Now, urbansplaining is when an urban clinician comments or explains something to a rural clinician, again, in a very condescending, overconfident way, and often inaccurate or oversimplified manner. Now, if anyone out there listening has ever been urban-splained, please feel free to throw something up in the chat section to share it. Share one of your stories with the others. All right, so urban-splaining may come from what I'm calling the Milne Myth. Now, this myth is that intelligence is inversely related to the distance you are from the city or the academic center of excellence or the ivory tower. So if you look at this graph, you've got intelligent quotient, your IQ, on the left, the vertical axis. And on the horizontal axis, you have the distance in kilometers you are away from the academic center. So the more rural you go, the farther you get, the more remote you are, the lower your IQ must be. Now, of course, this is absolutely not true. Some of the smartest people I know are rural doctors, and I've met some urban doctors that, oh yeah, I'm not supposed to say anything bad about somebody if I don't have something nice to say. So some urban doctors, let's just say, didn't stay up to date on the literature. So intelligence shouldn't be defined by a postal code, by the bricks and mortar, whether it's limestone or ivory tower, or even the technology at your disposal. The most important tool that any clinician has is the one between their two ears. But there is this stereotype of the rural doctor, and it is a white, oh my goodness, I'm starting to look like this guy. I've got the beard and stuff like that, lives on a farm, plaid's his favorite color, office attire involves wearing coveralls or overalls, driving a Ford F-150 pickup truck, and gets paid in chickens. That's the stereotype of a rural doctor. How about the stereotype of an urban doctor? Again, older white man, lives in a condo, wears a shirt and tie to the office, has a lab coat that has his name embroidered into it, enjoys good Thai food, makes lots of money, and drives a Tesla Model S. These are the stereotypes. But of course, the reality is much different. There are more women in medical school than men now. And not everyone identifies binary as either male or female. And doctors come in all sizes, all shapes, all colors. And it reminds me of a James T. Kirk quote from Star Trek, the original series. And I never pass up an opportunity to quote Star Trek and show my nerdiness. But there was an episode in the original series back in 1968, and it was called Plato's Stepchildren. And there was a character in it who was a little person. His name was Alexander, and he had no psychokinetic powers and was ridiculed by the rest of his society based on his size and his lack of certain abilities. And Captain Kirk sits down with him and says, Alexander, where I come from, oh, I should do it in my James T. Kirk voice. Alexander, where I come from, size, shape, or color makes no difference. And this is how I feel it should be in the House of Medicine. It shouldn't matter what the physician looks like, where they practice, how they identify. What matters is the quality of care they give to patients. So I would like to bring up the concept of evidence-based medicine because, evidence-based medicine is the lens in which I practice medicine through, and it does inform my experience with urbansplaining. And so I just like to make sure everybody has the definition of evidence-based medicine. Dave Sackett, 25 years ago, defined it as the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of individual patients. And I know if you're here at the first lecture, this is a bit of spaced repetition. Now, note, though, in the definition, it doesn't make a mention of urban or rural environments, but it does recognize the three pillars of evidence-based medicine: the best evidence, clinical judgment, and individual patients. And so, as you know, this evidence-based medicine definition can be summarized into a Venn diagram with the three pillars. And so I ruralized the Venn diagram just for this talk. I'm going to see if you pick up on some things here. So the blue circle in the bottom, that is the best relevant information that is rurally generated. So rural scientific evidence. And I want you to note that those are copies of the Farmer's Almanac that I put in there for the journals. All right. Now, on the right-hand side, in the green, you can see that it is the rural clinician, right? And the rural clinician has to have good clinical judgment. And a rural clinician will know their practice better than anyone else. They are the experts. They are the specialists at rural medicine. And then over on the left side, the red circle is the patient. And they're the expert at their own personal journey and experience. And that rural patient will have values and preferences. Now, these values and preferences may or may not be different than an urban patient. And I'm just going to go out here on a limb, just spitballing here. You know, the best way to know what a rural patient prefers or any patient prefers? Dramatic silence. Ask them what they prefer and what they value. All right, so let's look at those three pillars. The first pillar was the literature, and there are those farmers' almanacs again. And we do not have a lot of great rural research being produced. There are 6 million Canadians that are considered rural. That's about 19% of the total population. So 6 million Canadians, 19% of the total population are classified as rural. And if you go to one of the big funding agencies, the Canadian Institute of Health Research, they give out about $1 billion a year. That was my best Dr. Evil. I didn't go to Evil Medical School for 6 years to be called Mr. Thank you very much. But $1 billion per year in funding. And there was a study that looked over the last 20 years, how much of that funding went to rural research. And this was an article that was published by one of my mentors, Jim Rourke, in the Canadian Journal of Rural Medicine in 2019. And over the last 20 years, less than 1% of funding requests came from rural areas. And even a smaller amount, still almost like 0.5% of all the funding went to rural projects. So we don't have a lot of rural research funding. But there are lots of places that would love to take your money. Rural centers of excellence are out there and they need funding. And there are also a number of rural journals looking for high quality rural research to publish. And I want to thank, I put on that email list server, the Rural Medders. I put out a call the other day and said, listen, what do you know? Does anybody have rural research centers that they can share with me? This isn't all of them, but I collated a bunch of them and put them on this slide. So thank you to the audience who did that. Because we want to provide the best care to rural patients. And if we want to do that, we need rural research to inform our care. It's important that the cohort of patients are rural and not extrapolated from urban populations. This practice of urban-centric application of urban studies done on urban patients suffers from something called external validity to rural patients. So here's one example, and I'm really proud of it. I'm really biased too, but one example of a rural ACE. Now, rural ACE stands for a Rural Academic Center of Excellence. And that's the South Huron Hospital. And that's where I've practiced for the last 20 years. It's known as, and this is actually on their building, the little hospital that does. I just added research under that for this slide. But I took a look, and over the last 10 years, during a 10-year period, we published 50 papers or abstracts. 50 in 10 years. 5 a year on average, coming out of one small rural community and one small rural hospital. You can be a rural academic center of excellence because, you can be academic wherever you are. Academics should not be defined by a postal code. All right, another pillar of evidence-based medicine is clinical judgment. And sometimes we have more experience and sometimes we have less experience. However, I would say rural physicians have more rural experience than urban physicians. Now, I base this on face validity, but also the vast majority of rural physicians did some training in an urban environment. while a minority of urban physicians did training in a rural environment. I know many of the schools are now trying to give rural experiences to all their students. But again, the vast majority of rural physicians know what it's like to practice in the city because they did most of their training there, some of their training there. But when you look at urban physicians, a minority, I would say, did training in in rural environments. And then the third pillar is the patients and what patients value and prefer. That's that third pillar of evidence-based medicine. And we need to engage with them. We need to ask them. We need to be explicit and just say, what would you value? What would you prefer? And I say in clinical interactions with patients that I might be an expert at medicine and I have book knowledge and I'm a nerd and I looked at all that stuff. But the patient is an expert about themselves and they're an expert at what they value and prefer. And so I acknowledge their expertise. And this is similar to how I feel when I'm interacting with an urban clinician. I recognize that they may or may not have more information or a deeper understanding of this narrow medical problem we're discussing. However, I'm a rural medicine expert and I bring something of value to the conversation. And that's what the patients do, the rural patients. And if you are a rural clinician, you will understand. You won't roll your eyes. And I'll just pick an example of somebody who comes in a week later after they injured their ankle and you x-ray it and they've got a bimalleolar fracture, closed injury, but a bimalleolar fracture of their ankle. And I'm not rolling my eyes going, what the hell? Why did it take you so long to come in? What's wrong with you? You say, oh, you did it a week ago. What's happened in the last week? And they said, well, I had to get the beans off. I understand. Right? It takes place in a clinical context. And if they don't get the beans off in that week and this person just duct taped their boot, so it was sort of in a cast, they duct taped their boot to the clutch on the tractor and got the beans off. I understand. I'm here to help. All right. Perhaps this is why it bothers me when an urban clinician urbansplains something to me. It's probably how a patient feels if I approach them in a condescending, overconfident manner that oversimplify things and not recognize that they, as a patient, are an expert at their own personal journey and know themselves better than I know them. And that's what I'm looking for in a conversation with an urban physician, an urban clinician, that recognition that, you know what, I'm not an idiot, right? I understand rural practice. I understand this rural community. I understand this rural clinical condition, but I need your help in this area. All right, so what are the possible root causes of urban splaining? Well, I came up with a few here. One of them is that they're unfamiliar with the rural reality of rural practice. Some people may feel uncomfortable, that they're out of their comfort zone. I think burnout plays a big deal in how we behave with each other. And certainly during COVID-19, stress is increased, not decreased. And then a scope of practice. What are our scopes of practice usually? And I think all of these things can contribute to urban splaining. So like I previously said, most rural physicians trained in an urban environment, but very few urban physicians trained rurally. And they may have limited understanding of our resources. And one example I often get is when I'm asked, well, what does the CAT scan show? And I'm tempted. Oh, I'm just so tempted to say, I don't know, you can tell me when you get it because we don't have one. I try to preempt that and have a locus of control and say during the case discussion what resources we do and do not have, not to place that other clinician into that position where they have to ask you, well, what's the CT scan show? Because we don't have one. So I'll say in the conversation, well, I've seen this patient and we don't have a CT scanner, so I can't tell you what the scan is, but I'm hoping that you can facilitate that. It's some information that I thought you might think is important to have. So an urban physician just may be unfamiliar with the resources we have in rural environments. And we have to be kind at our end too. Understand that our colleagues, our urban colleagues, the closest thing they may have come to a rural environment is the dairy section of a grocery store. And I use it as an opportunity to educate each other, but not in a condescending way. I mean, you can't say, well, you mean you don't know that we don't have a CT scanner here? Of course we don't. We've only got a town of 3,000 people. Of course we don't have a CT scanner. Are you some kind of idiot? So not to feed back the condescending tone and the attitude in the conversation to try to mitigate urban splaining. We have to understand our urban colleagues and where they're coming from and their point of view and their frame of reference. And again, while many of us trained in urban environments, it can be difficult at times, though, to know what service to call for advice or help. I mean, in a smaller community staffed with general practitioners, who do you call about abdominal pain that the diagnosis is yet not figured out? In a secondary center, they may have gen surge and internal medicine, but that might be it, right? Whereas at a tertiary center, they may have internal medicine, GI, general surgery, urology, gynecology. And from a bias standpoint, it makes me think that whenever I call a service, it ends up being the wrong service. I mean, it would be nice if we could say to each other, I'm not sure if this fits with your service, but could you hear the case and just let me know if you're not the right person? Could you direct me to who is the right person? Or you end up calling two services. And this is, the situation. And the one service says, no, that's not my responsibility. That's the other's responsibility. And the other service says, no, that's not our responsibility. That's the other service's responsibility. Ugh, it can lead to frustration, which can come through in our interactions and lead to urban splaining. So as rural physicians, we might be out of our comfort zone too. I mean, rare things are rare because, well, they're rare, right? So they may be outside of our comfort zone. And so while we may see something once, twice in our career, rarely, the urban physician may have a weekly clinic dedicated to patients with temporal arteritis or multiple sclerosis or Ludwig's angina. And so we don't have the depth of knowledge. And so there's that dissonance between, yeah, geez, I call that Tuesday clinic on temporal arteritis, where I'm like, okay, do I get the biopsy? Am I allowed to start the steroids first? What's the dose of the steroids? What's the duration? How long do I have to get all these questions, because they don't come up that often. And it can impact our interaction and come through in that conversation that we're not feeling very comfortable. And that leads to some urban splaining in a very simplistic way. Communication can be another barrier and lead to us being more uncomfortable about a case. I mean, it was great, in an urban environment when you could hang out in the doctor's lounge, run into each other in the hall and have conversations, chat in parking lots. It creates a bond, right? It is much easier to be a jerk the farther you are away from the person that you're having the conversation with. So a conversation over the phone is much different. I really enjoy, even in small hospitals, running up and talking to the inpatient service as an emergency physician, or talking face to face with the general surgeon, or stopping by radiology and taking a look at a few things. I really think that has a benefit. And, we have telehealth in Ontario where calls are recorded for quality control purposes. And it's helped decrease some of that prior bad behavior on both rural and urban physicians have demonstrated. And sometimes we just need some reassurance, very similar to a patient who may call us working in a rural environment, trying to contact us about some anxiety they have about a medical condition, and they just need some reassurance. I think burnout is a big part of bad behavior by clinicians. I'm certainly been responsible for that in the past. When you're exhausted, and we're all exhausted at times. And everybody will have a cup size. And what I mean by a cup size is when your cup is full, it spills over. And some of us will have a itty little bitty orange juice cup size of a glass. Those ones that you get at fancy hotels, and it's like 4 ounces of apple juice or orange juice, and it costs like $20. But when that spills over, it spills over. And I've met other clinicians and I'm like, I don't know how they do it. They seem to have like this beer keg full, this huge size and capacity that I'm in awe of. But you know what? One drop more and it spills over. And when any of us, our cup is full, it's full, and our best behavior doesn't come out then. So when it comes to burnout, this was a term coined in the 1970s as a state of fatigue or frustration that resulted from professional relationships that failed to produce the expected rewards. Now, this most widely used tool to assess burnout is called the Maslak Burnout Inventory, or the MBI score. And it has three components to the MBI. It has emotional exhaustion as one, depersonalization, and reduced feeling of personal accomplishment. And I think all three of these things on the Maslak Burnout Inventory can lead to urbansplaining and bad behavior. So that first one is emotionally exhausted. Anybody here not ever been emotionally exhausted? I think it's something that we can all relate to. And it's not just being physically tired, it's emotional exhaustion. It's not, the number of hours or the effort, it's the emotional exhaustion. It's like when the well is empty, it's empty, and that there is no empathy left. Or you could think of it as the jar of I give a beep is empty. And when that jar is empty, it's empty, and you don't give a beep anymore. Emotional exhaustion. A second component to Maslak Burnout Inventory is depersonalization. And this is when we get angry and make disparaging remarks about our patients and our coworkers. Oh, they're idiots, right? We're short-tempered. And we can see this come across in the urbansplaining, right? And it's actually not that they're angry or upset or think we're idiots. It's that they're suffering from burnout. It's like, wow, that behavior seemed out of proportion to what we were discussing. I wonder if they're feeling okay. It's a flag for me to say, I should check in and make sure that they're okay. Because nobody went to medical school and at their med school interview said, I want to be a jerk. I want to mock patients. I want to yell at nurses. I want to give administrators the bird, right? We went into that med school interview saying, you know what? I'm a compassionate, empathetic, sympathetic person. I want to help people. So depersonalization. And the third is personal accomplishment. Physicians are amazingly efficient. We are the MacGyvers of the profession. If there's a way to figure things out, we usually do. But burnt out physicians can feel like they can't get anything done. They're just stuck spinning their wheels. And even the smallest task can seem like a huge burden. So you don't have this sense of getting anything done. You never get ahead of things. A 2015 study in the US showed that more than 50% of physicians had at least one symptom of burnout. I'm pretty confident in the days of COVID that number will be higher. And a recent survey was just published, I think 3 days ago now, and it said 3 out of 10 healthcare workers said they were considering leaving healthcare. I think that's the 3 people that actually answered honestly. I'm sure 7 out of the other 10 just didn't want to say they were thinking of leaving, but 3 out of 10 healthcare workers did actually respond and say they were considering leaving healthcare during COVID-19. Oh, went the wrong way. So one of the most common reasons cited for burnout is the electronic medical record. So please share your thoughts about EHRs in the chat. Isn't it great? Don't you love menus? Don't you love being a click center of excellence? Spending more face time with a computer than face time with patients? All those alerts and prompts. Oh, don't you? That's sarcasm, by the way, right? That's why I became a doctor. I wanted to be a super expensive data entry clerk. If there is someone who loves their EHR, there is a 12-step program for you. All right, so burnout can have negative consequences too on physicians. It can lead to depression, suicidal ideation, illegal drug use, increased alcohol and drug use. And we're seeing the numbers of increased alcohol consumption has gone up during COVID-19. And so it can really have negative consequences on physicians. And that burnout translates into negative impact on patient care, right? And there is an association between physicians who say that they're experiencing more burnout and those having more medical errors and impacting the quality of care. So if we're not healthy and not behaving well and being urban splaining, which may not lead to our well-being and stuff like that, we also can't take good care of our patients. And it starts with patient care and it ends with patient care. And that's our common goal, right? We want patients to have the best care based on the best evidence. But burnout can impact that. So some solutions have been suggested to mitigate physician burnout, hopefully less urban splaining then. West et al. In 2016 published a systematic review and meta-analysis, looked at different interventions to prevent or reduce physician burnout. One of the things that was suggested was mindfulness. So mindfulness as a way to mitigate, not to cure illness, not to rather end mental suffering, but just to mitigate burnout. And there are some studies out there in the medical profession showing that a mindfulness program can decrease stress and burnout scores. One of the best articles actually I saw recently on decreasing burnout and stress in healthcare providers was pet therapy and having a dog come in a separate room in the hospital that the physicians and other healthcare workers could go visit and have 5 minutes of puppy time. They had a significant decrease in their level of stress. Anyways, whether or not mindfulness training translates into long-term lasting changes and better patient care remains to be seen. All right, yoga has been suggested. However, physicians are not yoga-penic. They are not suffering from a lack of yoga. This is not why they're burnt out. And I don't want angry chats, saying, oh, you're anti-yoga. I'm not anti-yoga. If you like yoga and if yoga makes you feel better, do yoga. But wellness programs are not going to solve system-wide problems. And I think the worst thing you could do is force physicians to take a mandatory wellness module, unpaid, on the EHR. So people have argued that physician burnout that's leading to these bad behaviors, it's not burnout, it's moral injury. And moral injury has been defined as perpetrating or failing to prevent, bear witness to, or learning about acts that transgress deeply held moral beliefs and expectations. And it was originally described in soldiers responding to their actions during war. And there's a journalist, Diane Silver, who described it as, quote, a deep soul wound that pierces a person's identity, sense of morality, and relationship to society. And it's the moral injury of physician that is being unable to provide that high quality care to the patients they're caring for. And so this can come out in bad behavior and urban splaining. But I would assert that if half physicians are reporting some level of burnout, then it's a system problem, not a clinician's problem. Rather than pointing the finger and saying, you know what, you're just not strong enough. You need another class of yoga. You should do mindfulness. You're just not resilient enough. All your other colleagues are doing well with this. It's all about you. I would suggest if 50%, more than 50% of your colleagues are saying they're suffering from burnout in some capacity, it's a system problem. And these problems need to be fixed at a system level. And COVID-19, well, it's been a bit of a dumpster fire, hasn't it? And so I think that during these increasingly stressful times that kindness, empathy, and understanding become even more important. So this is one of my favorite quotes. I think probably kindness is the number one attribute in a human being. And I'll put it before any other things like courage or bravery or generosity or anything else. Kindness, that simple word, to be kind. It covers everything to my mind. If you're kind, that is it. And urban and rural physicians can disagree. We can disagree on management, the evidence, the best way forward in managing a patient. And we can disagree. It's fine. We don't need to be disagreeable. We can do it with respect for each other and leave out the condescending remarks and the tone out of our conversations. And again, did anyone go to their medical school interview when they were angry and when they were asked, hey, why do you want to become a doctor? Did you say, I want to be rude to patients? I want to yell at hospital administrators. I want to be really mean to nurses. And I want to urban-splain medicine to my rural colleagues in a condescending tone, filled with sarcasm. Of course not. That's not who we are. So we need to try to be more respectful with each other, kinder, even to ourselves. And remember, it's okay not to be okay. Another reason for urban-splaining may be the difference in scope of practice. This is the fourth point I wanted to make. So the difference in scope of practice. Rural physicians tend to have a broad scope of practice, and urban physicians tend to have a very narrow, focused practice. And this can create some problems when discussing patient management. And I love this one slide that I put together about rural medicine. What the hell is this? I mean, as a rural physician, you are often the ologist. You have to be the endocrinologist, the gynecologist, the cardiologist, the respirologist, the pediatrologist, the orthopathologist, the anesthesiologist. You have to be all of it because you might be the only physician in that entire community. So that is rural medicine. Whereas urban physicians can have a very highly focused practice, right? You can get an ophthalmologist who's on call, but they only really do the anterior chamber of the right eye. And you're calling with a patient who has a retinal problem of the left eye. And of course, that's an extreme, silly example, but you do get a whole bunch of subspecialization in urban practice that can often cover for the service. And so this might make it difficult for when you're calling in and having a discussion or you're sending in a consult on a patient. So let's circle back. Let's circle back now to the EM, evidence-based medicine, or EBM model of understanding urban-splaining. Consider the three pillars. Consider the rural scientific evidence that we have, and know that we don't have a lot of funding out there for rural research, but we have a lot of people that are interested in rural research. We have a lot of opportunities and sites that want to do rural research. And if we are going to inform our clinical judgment based on the literature, we need to we need the funds. We need to generate that rural research in rural cohorts of patients to inform the care of rural patients. But we also need to look at the rural patients themselves and ask them, what do you value? What do you prefer? What would you like to see being done? So if we remember that we're all in this together, that it's a team effort, and our common goal is that we want patients to get the best care based on the best evidence, then hopefully we can mitigate some of this urban-splaining. I can take my tongue out of my cheek and we can just try to be kinder to each other. So that's what I wanted to say about urban-splaining. And I see that we have lots of time now for questions and interaction. So I will stop my share screen and then I'll be able to see you guys and read some of the comments.